You're tuning in to another The Itch Review. Today we have a special collaboration episode with the American Thoracic Society. We're going to be talking about mucus plugging, a thick, sticky mucus that can block the airways and make asthma harder to control. We're breaking down the VESTIGE trial, a study that looked at how Dupilumab, brand name Dupixent, might help clear mucus, improve lung function, and make breathing easier for people with moderate to severe asthma. Don't forget that every The Itch Review episode comes with an infographic that highlights all of the key findings in the study. So grab that in the show notes and follow along. This podcast is made in partnership with the Allergy and Asthma Network. Now, let's get to it. You're listening to The Itch, a podcast exploring all things allergy, asthma, and immunology. We are talking about a paper called The Effects of Dupilumab on Mucus Burden in Patients with Moderate to Severe Asthma. It's published online in the American Journal of Respiratory and Critical Care Medicine, and that's on October 28th, 2025. And a quick shout out to my sister, happy birthday. So we haven't really talked much about mucus in this podcast and its role in asthma. So why don't we just jump off right there? Dr. Blaze, can you tell us a little bit more about mucus and mucus plugging?
Sure. So we'll start with mucus. And we talk about mucus in the lungs. Another word that sometimes we use is phlegm. You may also hear sputum, again, the material that you're coughing up. And we know that in healthy airways, we have that oxygen-rich airflow that goes through our airways. And mucus plays a really important role in healthy airways. In fact, it's very important as far as the lungs defense system because it helps trap things like irritants and helps our body get rid of them by coughing the mucus up. You also have in the lung, you have cells that have cilia on them. So what's cilia? That's kind of like fine hair-like structures that help move that mucus out of the airways. So all of this is very important because it helps protect us from irritants and infections. So with that, we'll move on and talk about mucus plugging. So mucus plugging, though, is the accumulation of thick, sticky mucus that can block or obstruct the airways in individuals. And we see this a great deal in our patients with severe asthma. And when this happens, we get in this mucus, not only what we call mucins, as we'll come back to in a minute, but we get high levels of inflammatory cells like eosinophils, which we've talked about many times before, related to type 2 inflammation. Also, we get accumulation that's part of the mucus of different proteins. We get cellular debris. We get different types of lipids. And very importantly here, and this gets back to understanding of the type 2 inflammation, is that we have a cytokine that we've talked about before, that being IL-13. So this is a type 2 inflammatory cytokine that has an effect on goblet cells. And these goblet cells in the lungs are the cells that produce mucus. And this mucus that they produce when someone is having problems with asthma, one of the elements is called Muc5AC. And this is very thick and sticky. So it adds to the thickness, or what we call the viscosity of the mucus. And because of this thick mucus that we're now getting because of the inflammation, we can get mucus plugs. In other words, again, that accumulation in the airways, which can obstruct the airways.
So what I'm hearing is that mucus is typically a good thing. So we have mucus, and mucus plays a role, and it helps get things out of our lungs that we don't want to have there. But what happens is, for some people, we have more inflammation, and that happens because of all of these different cells and interleukin-13 that Dr. Blaze mentioned. And what happens is, because you have too much inflammation, the mucus changes and it gets thicker and it holds on to more stuff that it normally would not hold on to, like lipids and other types of cell debris. So the mucus gets thicker and it kind of plugs your airways, right? I hear mucus plugging, I think of like putting a plug in a bathtub. And so it's stopping something from being able to move through easily. So that's what I'm hearing, is that mucus in essence is not a bad thing, but when it gets inflamed and then it gets thicker, then it causes problems. And for people with asthma, it causes problems.
Exactly. Yeah. So you just think about mucus as a sticky goo that goes through and captures anything that shouldn't be in there. And then our body, through with the cilia, those little hair like structures, can then cough that up and get it out of our body. And then if we have too much of it and it's too sticky and too thick, the cilia can't get it out. And then it gets stuck in our airways. And of course, a sticky goo in a tube, which is what our airways are, is not good, right? Because we want airflow to go in and out of our airways. In this case, it's a pipe that's getting clogged and you can't get air through it anymore. So, mucus plays a really important part in our defense system. And I quickly want to talk about asthma because we've talked about it in multiple episodes, but we always want to do a refresher for anyone that's just listening to this as their first episode. So, asthma is a chronic lung condition. It has two different components. One is airway inflammation, which is also swelling of the airways. And of course, if we have swelling of the airways, that makes it difficult to breathe. And then the second component is that the muscles around the airways also tighten more easily than they should. And that also reduces the airflow that's going through our airways. And so both of these, again, lead to difficulty breathing. And the symptoms that people will experience are shortness of breath, wheezing, chest tightness, and coughing. And again, we have a lot of episodes on asthma, and we'll link them to the episode for people who want a deeper understanding of what asthma is. But for today, it is important to remember that asthma is a chronic lung condition that makes it hard for people to breathe. Another thing that everyone needs to understand for the study is that there are different severities of asthma. So when a doctor sees someone with asthma, they will ask them a series of questions and they will also do breathing tests. And that will determine if they have mild, moderate, or severe asthma. So if someone has more frequent symptoms, they need to use their medications more often because of those symptoms, and their lung function testing or the breathing tests that they do to see how good their lungs are working, those will also be reduced and not working as well as they should be in more moderate to severe asthma. That is some basic information that we're going to need in order to be able to understand the study.
Thank you, Dr. G. One question about moderate to severe asthma. Are these patients who take an inhaler every day?
So once we determine that you have moderate to severe asthma, we will put you on what's called a controller medication. And that means that you will be on a medication on a daily basis. If it's one of the inhalers or one of the biologics, you may be on injections, and those are usually given every 2 to 4 to 6 weeks. It really depends on the dosing of those medications. But in general, yes, you will be on a medication to control that inflammation or swelling in your airways, as opposed to just being on a rescue medication, which a rescue medication is a medication that we use for people with asthma. When they're having symptoms with their asthma, they need something to help open up those airways. So that's what a rescue medication is. And that's something that people with asthma carry around with them all the time.
Great. Thank you so much for clarifying that. Now, we understand that asthma has the two components, the swelling and then the muscles. And now we're adding in something called mucus, which we just discussed. And I can only imagine that if you have swollen lungs already and you're adding in mucus, it's going to make it really, really hard to breathe. Before we move on, I have one more question, and that's, is the mucus produced in the lungs?
So, yes, absolutely. And the airway blockages that are caused by this mucus buildup, as we've been talking about, just makes it harder to breathe in both sudden and long term asthma problems. And unfortunately, sometimes, in fact, the mucus plugging can be so severe, the airflow so restricted that, in fact, death can occur in people with asthma. So we know the research shows that the more mucus that's developed and the more plugging, the worse lung function we have. So lung function is a way that we can test someone's lungs to see how well that they are breathing. And in this situation, the test will be worse as the mucus increases in the lung. And there's something else that we usually measure here in many cases, and that's the mucus plug score. So we talk about a mucus plug score. It's a way to measure how thick and sticky the mucus is that's blocking the airways in the lungs of someone with asthma, and get a degree of how much blockage is occurring in the lungs. So what we know now is that the higher the mucus plug score is that we see in our patients, the worse their asthma lung function tests are. So common asthma treatments that we use, like inhaled corticosteroids and oral corticosteroids, and even when we give steroid injections, they just aren't very effective as far as reducing that mucus blockage that is occurring in the lungs of these patients. So the researchers here for this particular study wanted to find out if a newer type of medication could in fact help reduce the mucus plugs. So in this study, we're looking at a certain biologic. The generic name is Dupilumab and the trade name is Dupixent, which I know we've discussed before on this podcast.
What I'm hearing is that the medications that we've had so far that treat asthma have never really addressed the mucus. And that's what this study is looking at. They're looking at, is this particular medication, Dupilumab, going to help essentially get rid of the mucus? And how does Dupilumab work, Dr. G?
So Dupilumab has been approved for many conditions, including asthma, for a long time. Dupilumab is a biologic that is a type of medication that's made from living cells and not chemicals like most other medications. So they're designed to target specific parts of the immune system that cause disease. So with Dupilumab, it helps target the parts of the immune system involved in inflammation or swelling, and it essentially helps reduce the swelling. And in this case, we are talking about reducing swelling in the airways because we're talking about asthma. Dupilumab blocks interleukins, which we have also discussed in the podcast, which are chemicals in our body that when they're released, they lead to that swelling or inflammation. The two types of interleukins that we need to keep in mind for Dupilumab are IL-4 and IL-13, because that is what Dupilumab blocks. So specifically, they do this by blocking a receptor called the IL-4 receptor, and that inhibits both the IL-4 and the IL-13 from causing swelling in the airways of people with asthma. And it also reduces IgE production. So IgE is another type of immune cell that we've talked about. It's an antibody that's involved in allergic reactions and also can cause inflammation and swelling. And the reason that we're talking about this medication for mucus is because the IL-13, as Dr. Blaze mentioned earlier, is very important in the production of mucus that may be playing a role in worse asthma. What the researchers wanted to see was, does reducing that IL-13 and blocking it, would it help end the mucus plugging that we see in moderate to severe asthma patients? And the other interesting thing about IL-13 is that it also affects the ciliary beat. And what that means is that the way and how effectively the cilia function is affected by IL-13. And IL-13 makes the cilia, which are those little hair-like cells that help get the mucus out of our airways. It also makes that cilia not work as well. So those two things, the mucus production and the way that the cilia work, are both made worse by IL-13. And that's why the researchers wanted to look at Dupilumab or Dupixent to see how much it really does help with mucus plugging.
Thank you very much, Dr. G. So basically what I'm hearing is that Dupilumab targets two different things, IL-4 and IL-13. But in this particular case, we're focused on IL-13 because it plays a role in the mucus production and making it super thick, and also in the cilia, which help clear out the things you don't want in your airways. And so if we target that using the medication, hopefully we're going to see less mucus and the cilia is able to do its job better. Now that we've set the foundation, can we talk about the study that this paper is discussing?
Sure. So this study was called VESTIGE, and this is a multinational randomized double-blind placebo-controlled phase 4 study. So let me kind of break that down so that we could understand this better. So what they did in this study, they looked at an adult population, 18 to 70 years of age with asthma, that was not controlled and had moderate to severe disease. So these patients had worse asthma. So these patients were put into two groups randomly to either receive Dupilumab or to get a placebo, which we know is pretend medication. And the people in this study didn't know what group they were in, and the doctors who were treating them didn't know what treatments they were getting. That's why we call this a double-blind study, meaning that no one treats any group differently. Both the patient and the doctor find out at the end which group the patient was in. In addition, in this study, we also see a type of asthma where the immune system makes too many certain cells. In this case, we talk about measuring the eosinophils that are in the blood, and that number had to be greater than or equal to 300. So again, this goes along with that type 2 inflammation. And they also looked at a special breathing test that can be done in patients by having them blow into a machine, and this is called fractional exhaled nitric oxide, or FeNO. And this test gives us a number. And when this number is high, it means that there is more swelling or inflammation in the airways or the breathing tubes.
The first time we had you on the podcast, Dr. Blaze, was to talk about type 2 inflammation, and that's how I know about it. And that's because if they have a high eosinophil count, does that mean they have type 2 inflammation? And if they have type 2 inflammation, they are a good candidate for taking Dupilumab?
Yes. So generally, one of the biomarkers, one of the tests we can do to determine if a patient with asthma has type 2 inflammation is in fact measuring the blood eosinophil count. And if it's above that 300, that gives us a good indication that that patient has type 2 inflammation.
And the second thing you mentioned was the FeNO, and I always called that FeNO. I'm not sure if you call it FeNO or FeNO, but I'm just going to say FeNO, and then you correct me if I'm wrong. But they did that test to see if the lungs were inflamed, because we're looking at inflammation also in this trial.
Yes, so FeNO or FeNO, all those terms are all absolutely correct. We know that IL-13 leads to a release of an enzyme that we call nitric oxide synthetase. And it's important as far as production of nitric oxide. So the more IL-13 we have in the lungs, the more of the exhaled nitric oxide, or as we measure FeNO, would be measured. So we know that IL-13 is important in type 2 inflammation. So again, it's another biomarker that tells us that in fact the patient has type 2 inflammation.
Great, thank you. So once they determined this group of patients, they decided some got Dupilumab and some didn't, and the researchers didn't know who got it, and the patients didn't know if they got the Dupilumab or the placebo, which is the fake medication. Were there other things that they were looking at in this patient population, Dr. G?
Yeah, so the patients actually had to have several other factors. They had to have a history of at least one severe exacerbation in the previous year. And what we mean by exacerbation is their asthma suddenly gets worse, which is not good and can be dangerous. So that also is a sign of moderate to severe asthma. And they also had to have greater than or equal to 1.5 on a 5-question asthma survey called the Asthma Control Questionnaire. And a score of 1.5 means that someone's asthma is not controlled. So they also took that questionnaire to determine what their score was on that. And then as well as the FeNO or FeNO breathing test that they had done, they also had another breathing test called spirometry, which is another way of looking at how the lungs are working. Here, we're looking at a value called FEV1, which is forced expiratory volume in 1 second. And that basically means how much air a person can blow out of their lungs in 1 second. And we know what the normal values should be for people that are a certain weight, that are height, their gender, and factor into how much you should be blowing out in 1 second. And we know what normal is and we know what abnormal is. If that number is less than 80% of normal, it means that the person's lungs are not working as well as they should, and that the airways are tight or they have a lot of swelling in the airways. And so we measure that before they've taken any medication in the office. The next thing we do is we can do a post bronchodilator test. And what that means is we give them the medication that we usually use when they're having immediate symptoms, so the rescue medication, and that medication is albuterol. And when we give them albuterol, their FEV1, if they have true asthma, should get better. And usually we say that that number should improve by 12%. So their FEV1 percentage should go from less than 80%, whatever that was, and improve by 12%. That will define them as having asthma. So they also did that test to confirm that. So there was also one thing that they looked at where it would exclude the person from being in the study. So oftentimes people with moderate to severe asthma, can we put on oral corticosteroids? Those medications, again, reduce swelling in the airways. We don't like using them in asthma patients or in any patient really for any condition anymore because we have better medications. But in this situation, they considered chronic steroid use as being on oral corticosteroids for more than 2 weeks. So if they found that any of these patients had been using oral corticosteroids for more than 2 weeks, before their first visit into the study, they were excluded from the study. And so once they looked at all of those parameters, they were able to find 109 adults with moderate to severe asthma. And as Dr. Blaze mentioned, they were put into 2 different groups, one that got the medication and the other one that didn't. And this was done in a 2-to-1 fashion, meaning that for every 2 people who got Dupilumab, which in this study was 72 patients, there was 1 person who got placebo or the dummy medication, and that was 37 patients. Also, these patients continued their normal asthma medications while they were getting the Dupilumab or while they were getting that dummy or placebo drug every 2 weeks for 24 weeks. And then every patient also had that special lung scan. So that's called a high resolution CT or computed tomography scan. And as we mentioned earlier, the reason that they did that was to be able to understand what the patient's mucus plug score was. So they did that at the start of the study, then they did that at 4 weeks, and then they did that again at 24 weeks at the end of the study to be able to compare what the mucus plug scores were. And one thing I wanted to mention is that we don't normally do high resolution CT scans for our asthma patients. It was specifically in this study to see if we can make a difference in the mucus plugs.
So it sounds like they actually did a lot of tests to see if these patients were able to participate in this study, and they really wanted to make sure that they had asthma, first off, moderate to severe asthma, and they wanted to see if there was swelling, right? In the special test that you mentioned, Dr. G, the mucus plugging score to see basically whether they have mucus and if after 24 weeks they have a little bit less. So after they did all of these tests, what did the patients in the study look like?
So at the start, most of the patients that were part of the study had a lot of mucus plugging going on in their lungs. 71 patients, or about 2/3, had a high mucus plug score. So that was 64% of the patients that were in the Dupilumab group and 68% of the patients that were in the placebo group. And 33 patients, so the other 1/3, had a low mucus plug score. And that was about 32% of the patient in the Dupilumab group and 27% of the patients in the placebo group. So they looked at mucus plug scores, and at the start of the study, the people with a lot of mucus plugs, that high mucus plug score, on average had a score of about 9 to 10. And those with fewer plugs, so the lower group, had scores about 1 to 1.5. Again, the higher the score, the more airways that were completely blocked by mucus. So when we talk about a mucus plug score, it's scoring from 0 to 20. And how this works, again, we do that high resolution CT scan and we look at 10 lung segments on each side. So you have 10 segments in the right lung and 10 segments in the left lung. And then we score this from 0 being no mucus plug to 1 being a mucus plug is present. Since we have a total of 20 lung segments, the highest score would be a 20. And of course, the lowest score, where the lungs were completely clear, would be a 0. So these mucus plugs, I think, and we've mentioned this before, but it's very important to remember, is strongly linked to the amount of mucus volume that is seen on the lung scans, meaning the higher the scores, the more mucus buildup in the patient's lungs. Now, it's important to note in this study, the most of the participants, in fact, were women. They were non-Hispanic and they lived in Eastern Europe, and most of them had never smoked. So overall, the Dupilumab and the placebo groups here really looked similar at baseline. They had similar ages and sex distribution, and those inflammation markers we talked about, the eosinophil count and the FeNO, and their asthma history. And as expected, people who started with more mucus plugging also had worse lung function and smaller airway volumes at the beginning of the study compared to those with lower mucus scores.
So it sounds like you had the two groups. You had the placebo group and you had the Dupilumab group. And after looking at all of these different criteria, they were able to say, okay, we're going to start the study. And both of those groups look quite similar. And now that they have these two groups, what were they looking for? And I know this beautiful term, endpoint. So Dr. G, what were the endpoints of this study?
Yes. So as we've learned with our journal clubs, there is primary endpoints and there's other secondary endpoints. So the primary endpoint or the main goal of the study was to look at the mucus plugging and the effect that Dupilumab or Dupixent has on that mucus plugging. So the study looked at how many patients had different levels of mucus plugs at the start, after 4 weeks, and after 24 weeks. And then they also checked how the overall mucus plug scores and the mucus volume in the lungs changed from the beginning to these specific time periods. So, for the secondary endpoints, they actually looked at a lot of different breathing tests. And they looked at these breathing tests for the people that had high mucus plug score versus low mucus plug score. So, they looked at the FeNO level. And really quick, just to give you parameters in case you're actually looking at the study and reading it, a low FeNO level is less than 25, and that means there's little to no airway inflammation. 25 to 50 means there's some airway inflammation, and greater than 50 means that there's a lot of inflammation in the airways, and we usually think that that's due to allergic or eosinophilic asthma. They also then looked at a lot of different breathing tests in these patients. I'm not going to go into all of them, but essentially what you need to know is that they compared the low mucus plug people and the high mucus plug people during the study in order to really see how much of a difference it's making in their true breathing, right? In their ability to breathe. And they specifically also looked at what we call small airway breathing tests. So your airways go from larger to smaller. And those small airways can really get plugged up. And sometimes the medication doesn't reach that far. And so those small airways can be very important in somebody with asthma and how well they do with different types of therapy. And so they also wanted to see how much are those small airways affected in these patients and how much can we improve their small airway disease while doing this study.
Now that we know what they were looking at, what about those results? What did they find?
When we're talking about the mucus plugging, which again was the major endpoint related to this study, Dupilumab made a big difference in how much mucus was blocking the airways. So at the start of the studies, we mentioned about 2/3 of the people on Dupilumab had a high mucus plug score. But after just 4 weeks, it dropped to about half, just 51% now. And by 24 weeks, only 1/3 of the patients, or 33%, still had a high mucus plug score. Now, if we contrast that with what we saw in the placebo group really didn't change at all. Again, about 3/4 of them still had a high mucus plug score again throughout the entire study. Now, the CT images that were seen in the paper showed that's what it looked like, that you could literally see a reduction in the mucus plugs in the people taking Dupilumab compared to the group that was on the placebo. When researchers looked at how much of the total mucus plug score dropped, Dupilumab clearly outperformed the placebo group, no matter whether the people were on high or medium dose inhaled corticosteroids during the study. And also, Dupilumab also reduced the mucus volume seen in the lungs, again, much more than what was seen in the placebo group. And then, very importantly, Dupilumab helped calm down that inflammation. About half of the patients with lots of mucus plugs and 2/3 of the patients with fewer mucus plugs reached a low FeNO level of less than 25 parts per billion, meaning that their airway inflammation went down. The placebo group, only 10 to 12% reached the same level. So that means the patients that were taking dupilumab were 6 to 8 times more likely to have improvement in their lower airway inflammation by the end of the study compared to the placebo group.
So those results sound like they are significant. And just to reiterate what I heard, the people taking dupilumab saw their mucus plug scores drop, which means that when they did the scans after the 24 weeks, they found that there were less mucus in the areas. When they took the images, they saw less mucus. And when it came to measuring swelling, they also found that the group taking the dupilumab had a significant decrease in lung swelling. And in the placebo group, they didn't see any change in the mucus. What about the other endpoints that you mentioned, Dr. G?
The secondary endpoints, I just want to clarify, we're looking at the dupilumab treated group and specifically the people who had the high mucus plugging versus the low. So remember that 2/3 of the patients in the dupilumab group at the beginning had high mucus plugging and 1/3 had low mucus plugging. So they looked at those particular patients and looked at the difference between the people who were on dupilumab with the high versus the low. So we're not comparing it to the placebo, we're just comparing it within that dupilumab group. So the secondary endpoints, there's a lot of different numbers that we can look at with these breathing tests when we do them. And I think it would be overwhelming to go through every single one of those numbers and try to explain them in this episode. But essentially what they found was that from patients who got the dupilumab versus the patients that didn't, we saw the best improvement with dupilumab in the patients that had a heavy mucus burden at the beginning. So that's really important to remember because we're always trying to figure out which medication might be the best for which patient, right? And so in this situation, what we're seeing, at least in this study, is that people with a high mucus burden, moderate to severe disease, when they get dupilumab, their breathing tests improve more than people with a low mucus burden and moderate to severe asthma. So it's just helpful for us to understand exactly what kind of patients may benefit the most from certain medications. And we still saw improvement for people who had a low mucus burden, but the people with the higher mucus burden or more mucus plugging just showed more improvement in those breathing tests when we looked at before dupilumab and after dupilumab.
If I can just summarize to see if I understood that correctly. So what Dr. Blaze mentioned was that comparing the placebo group and the group that were taking dupilumab, the group on dupilumab had significant results, meaning that they had less mucus and that they had less inflammation. And then what Dr. G was mentioning is they went even further and looked at what was happening within the group who were taking dupilumab. The people who had more mucus plugging at the beginning, so people who had more mucus plugging, they had more significant results than the patients who had less mucus plugging when it came to how well they were able to breathe. Is that correct?
The bottom line is when you don't have mucus plugs, the air is getting in pretty well. So you're not going to see much difference in lung function versus the group that now you're clearing those mucus plugs, you're opening up the drain so the airflow can go. And that's kind of the bottom line here as far as why you didn't see a big change in the low mucus plug people.
So one thing we do want to talk about is a concept called limitations. And what that is that, studies are designed to be as robust as possible. They are trying to make sure that the data that they give you at the end is trustworthy. But of course, every study can't be pitch perfect, if you will, and there are certain things that could potentially impact the way that we read the data. And that's what we're looking at when we talk about limitations. So, Dr. Blaze, did this study have any limitations?
So it did have a few limitations that I think are important to mention. This was a post hoc analysis, meaning that it wasn't designed ahead of time to study that high versus low mucus plug groups. So the patient numbers here were fairly small. And the study population mostly had high FeNO and high eosinophils. So the results may not apply to all asthma patients because we know that there are a group of patients that have non-type 2 inflammation as far as their condition. And then there was limited diversity in these participants. Again, most of these patients were white Eastern European. And we also have to remember that the CT scans couldn't perfectly distinguish mucus in some cases from the airway walls. So that can lead to some uncertainty. And then the study cutoff that we use for high mucus plugs, that greater than 4 mucus plug score, has been validated, but it may still need refinement in future studies.
So basically what I'm hearing, and just so we can understand why we call this limitations, is that, it was looking at a more specific type of person, not a huge diversity of the people that were in the study, and that the people who were in the study also had high levels of eosinophils, so they had a very specific type of asthma. And so that means that we can't necessarily say that what this study is telling us also applies to other people with asthma who don't have high eosinophilic count. So that's why we call it limitations, because it doesn't mean that we can apply it to every asthmatic person. Well, I feel like this has been very interesting to hear. I always love these journal clubs because I learn something new every time. So with that, Dr. Blaise, Dr. G, can you tell us your takeaways of this study? Let's start with you, Dr. Blaise.
So I think this is very important data for all of our patients with moderate to severe asthma. And it was interesting to see how well Dupilumab did as far as reducing those mucus plugs, along with lowering that inflammation and improving lung function in those patients. I thought it was also very interesting that we saw changes as early as 4 weeks. So I think that's very important for the patient population also. So again, I think this gives us some very important data because we see these patients that have a great deal of mucus in their lungs, impairing their ability to breathe. And now knowing from this data that we have a very effective treatment for that.
Yeah, and for me, I echo those same statements. I think it's always nice to understand, especially for allergists, we love understanding the exact mechanism of how we're helping our patients with the medications that we're choosing. And so in this situation, we're able to see that mucus plugging, which we know can be an issue now for our asthma patients, looks like it's being treated by Dupilumab or Dupixent. And I know that other biologic medications are also looking at mucus plugging and how effective those medications are also in mucus plugging. And so it's just very helpful to know exactly how we're helping our patients with these different type of medications.
Thank you so much. And if you're interested in more asthma content, we've done quite a bit on this podcast, so we will make sure to link that if you want to hear more about type 2 inflammation and our other episodes on Dupilumab. So thank you so much, Dr. G. Thank you so much, Dr. Blaise, for shedding some light on this study.
Thank you for listening to today's episode. Remember that all information you hear today is for informational purposes only and are not intended to serve as a substitute for the consultation, diagnosis, and/or medical treatment of a qualified physician or healthcare provider. And also, don't forget to subscribe to our podcast. And if you have a second, help spread the word by rating our podcast and sharing with your friends and family who might also be interested in learning more about allergies, asthma, and immunology. You can always stay up to date by checking out our Instagram, The Itch Podcast, where you can leave questions you are itching to know, or check out our website, which is www.itchpodcast.com, which contains more information about the subjects we covered in today's episode and every episode. Until next time, have a fabulous week.